Welcome to our video on principles of cancer screening and prevention. Let's get started. Here's our overview slide. Specifically, we will go over screening and prevention strategies for lung cancer, breast cancer, cervical cancer, ovarian cancer, then prostate, and then colorectal cancer. So we'll start with the lung. Annual screening for lung cancer with a low-dose CT scan is indicated in patients who meet a certain set of criteria. Now, it's important to note that the United States Preventive Services Task Force, or the easy acronym being USPSTF, just kidding, that's not easy. But anyways, that organization recently introduced slight changes to those guidelines. So for that reason, this slide includes both the old guidelines and the new slight modifications to those guidelines. Okay, so the old guidelines are as follows. They're age 55 to 80. They have a 30-year pack year history of smoking, or more than that, so 30 or more pack years. And the patient is a current smoker or quit smoking within the past 15 years. So basically, age and some smoking history criteria. Now, most exam questions written on this subject for the next several years will still likely rely on these old guidelines rather than the new ones. But here's what you need to know about the new guidelines. The new guidelines introduce two key changes. First is to begin screening at age 50 rather than age 55. And the second is to screen people who have a 20-pack year history of smoking instead of a 30-pack year history. And the criterion regarding being a current smoker or having quit smoking within the past 15 years has not changed. So basically, what you can remember is that the new guidelines just decrease the threshold for which you would screen somebody. So you're actually going to be screening more people, younger people, so age 50 and 20 pack years instead of 30 or more pack years. Lastly, clinicians should consider not screening patients with a limited life expectancy or patients who are not willing to pursue treatment for lung cancer. Remember, the goal of screening is to identify cancer at an early stage in order to treat it. And if the patient is too frail or does not want treatment, then there's no reason to screen them for cancer, right? You're not just trying to identify cancer for the sake of having identified it. You're trying to improve their lives or extend their lives. When it comes to lung cancer prevention, smoking cessation remains the number one recommendation. Now we're moving on to breast cancer screening. Breast cancer screening guidelines vary from one medical organization to another. Generally speaking, breast cancer screening in the general population is accomplished with a screening mammogram that is performed every 2 years in women who are between the ages of 50 and 74. A familial risk assessment tool is indicated in higher risk women. Those are those with either a personal or family history of breast, tubal, ovarian, or peritoneal cancer, or a known gene mutation, specifically BRCA1 or BRCA2. And that gene mutation can be identified in the patient or in their family. Either way, they have an increased risk. Now, notably, breast self-examination is no longer recommended in average risk women. And that's because studies have found that self-examinations lead to many unnecessary tests and anxiety without actually improving breast cancer-related morbidity or mortality. But that one's still kind of controversial, and different doctors feel differently about that. But since there's confusion surrounding that and not everyone agrees, then you should know that regular breast self-examination is almost never the correct answer on exams. Now, several factors have been associated with decreased incidence of breast cancer in the general population. Childbearing, especially in early life, and breastfeeding have both been associated with a lower risk of breast cancer development later in life. Avoidance of tobacco and alcohol, which are both notorious carcinogens, can also reduce one's risk of developing breast cancer. And risk-reducing medications, such as tamoxifen, raloxifene, and aromatase inhibitors, can reduce the risk of breast cancer development by reducing the exposure of breast tissue to estrogen. And those medications are typically used in high-risk patients who are unlikely to experience significant side effects from those medications. So pausing right here for a moment, just think about breast cancer prevention as being related to estrogen, either in the form of having children early in life, breastfeeding, and then also using medications that directly block estrogen activity at the receptors. And then, of course, as with almost all cancers, just avoid those carcinogens. Now, lastly, prophylactic mastectomy can be considered in certain high-risk patients, which basically means those with a BRCA mutation. And by removing the breasts, you've basically nullified the risk of breast cancer development. Now let's move on to ovarian cancer. So ovarian cancer screening is indicated in women with a family history of any one of the following factors: male breast cancer, bilateral breast cancer, diagnosis of breast cancer at age less than 50 years old, multiple instances of breast or ovarian cancer, and 3 or more relatives with cancer secondary to Lynch syndrome. So any one of these issues can warrant ovarian cancer screening. Now, how do you do it? Well, screening for ovarian cancer usually begins with genetic testing for high-risk mutations, such as mutations in BRCA1 or BRCA2, and in mutations that predispose patients to Lynch syndrome. Now, if genetic testing identifies a high-risk mutation, clinicians should obtain a CA 125 level as well as a transvaginal ultrasound on their patients twice a year. And you're going to start that at age 30. So that's how you screen for ovarian cancer, but how do you prevent it? Well, the strategies for ovarian cancer prevention actually depend on whether genetic testing for high-risk mutations was positive or negative. In the setting of positive genetic testing, salpingo-oophorectomy is recommended to all women who no longer desire to bear children. And that makes sense because if you just remove the organ that can become cancerous, then you're removing that risk of that cancer. Now, in the setting of a negative genetic test, oral contraceptive pills are recommended for premenopausal women. And then if they're postmenopausal, you can also consider a salpingo-oophorectomy. And that's logical because they're postmenopausal. They're not going to have kids at this point, so you might as well remove those organs which can likely cause cancer. Now let's move on to cervical cancer screening. This is generally indicated in all women ages 21 through 65. Now the key to remember about cervical cancer screening are the screening modality and the frequency of use. In females ages 21 through 29, screening is recommended with cervical cytology, that is pap smears, every 3 years, assuming the results of each pap smear have been normal. So pap smear every 3 years. But in females ages 30 through 65, there are actually 3 viable screening options. So cervical cytology alone every 3 years, so that's very similar to what they were doing in their 20s, or cervical cytology and HPV co-testing every 5 years, or HPV co-testing alone, so it wouldn't be co-testing at that point, it would just be HPV testing every 5 years. So basically pap smear plus HPV testing, or just HPV testing. But how do you remember the years? Well, in whatever option you have, if HPV testing is involved, then it's every 5 years. But in just the pap smears, it's every 3 years. And one key difference you can see between these two age groups is that the younger females aren't recommended to have HPV co-testing. And why is that? And the reason that HPV co-testing is not indicated in younger women is due to the high prevalence of high-risk HPV infections in this younger population. In other words, you're so likely to get a positive HPV test, but it won't actually help you in your management of cervical cancer or your patient, that you don't even do it. So you just want to do the cervical cytology or do the pap smear because that's what you're worried about. It's only later when they're older and they're not as sexually active and you're not as worried about HPV infections that you can actually start testing for it, which may seem counterintuitive at first, but that's how it's done. Now, there are 3 main special scenarios to know about when it comes to cervical cancer screening guidelines. If the patients are immunosuppressed, it is recommended to perform annual cervical cytology with HPV co-testing regardless of their age. Now, for patients with HIV, the recommendation is to perform annual cervical cytology until there are 3 or more normal results. At that point, these patients can be resumed on a regular screening schedule. And that's fairly intuitive. If they've really proven that they don't have cervical cytology or positive pap smears indicating a possible cervical cancer, then they've earned their position in a regular screening schedule. And by regular screening schedule, I'm referring to the cervical cancer screening that we had on the previous slide, where you have ages 21 to 29, you just think pap smear every 3 years, and then ages 30 and up to 65, you can default to those as well. So HIV patients who earn normal results 3 times, then you can default to that. Now lastly, for patients who had a hysterectomy, at which time the cervix was also removed, then there's no screening indicated, especially if the patient is low risk and all prior appropriate screening has been negative. And again, that's pretty intuitive. If you remove the cervix, then you're basically removing the risk of cervical cancer. Okay, so that was cervical cancer screening. What about prevention? Well, cervical cancer prevention is accomplished first and foremost with vaccination. And the HPV vaccine, which is usually Gardasil, can be given to males and females ages 9 through 45. Though the routine vaccine is typically given to kids age 11 to 12. Now, in the past, the vaccine used to be approved only for people ages 9 through 26. However, within the past year of this recording, the HPV vaccine has been approved through age 45. And it's possible that this change may be reflected on the boards. Now, lastly, a patient's vaccination status does not change the recommendations for cervical cancer screening in any way. And that's actually fortunate for you, so you don't have this extra layer of complexity. So just because you're vaccinating your patient and you see that on a board style question, patient's vaccinated, it changes nothing about these cervical cancer screening guidelines that we just taught you. And examiners may be trying to test that point. So remember, HPV vaccine is good, recommended through ages 9 through 45, but you still can remember and follow those prior screening guidelines. Now let's talk about the last part of prevention. In addition to vaccination, safe sex practices, such as consistent use of condoms, is always recommended to help prevent spread of sexual transmitted diseases, including HPV. So when you're asking your patient, do you use protection? They might say yes, but what you really want to know is if they always use protection. Let's do a quick question. Is cervical cancer screening indicated in otherwise healthy women aged 21 through 65 who are not sexually active? The correct answer is yes. Cervical cancer screening is indicated in otherwise healthy women ages 21 through 65 who are not sexually active. Even though the risk of contracting HPV and developing cervical cancer is very low in women who are not sexually active, most American medical societies, including the American College of Obstetricians and Gynecologists, recommend cervical cancer screening even in this population. Now, the reasoning behind this recommendation actually varies from organization to organization, so don't try to understand exactly why, even if it's not super intuitive, but just remember that the main reason seems to be that patients may not always want to disclose their sexual activity, or clinicians may not always gather the most comprehensive sexual history. And since the morbidity and mortality associated with cervical cancer is so high, most medical organizations still consider it beneficial to screen women even if you discover or they disclose that they are not sexually active. Let's look at this from a different perspective. Is cervical cancer screening indicated in otherwise healthy sexually active women who are younger than 21? So in this case, we have almost the exact opposite situation. This patient does not fit the age group that we discussed before. They're not 21 and up, but they are sexually active. So where does that put us? Should you screen them? Well, the answer is no. Cervical cancer screening in women younger than 21, even if they're sexually active, should not be screened. And that's because most abnormal cells that would be detected on a pap smear in a young woman will usually return to normal without intervention. And due to low likelihood of needing an intervention, cervical cancer screening is not indicated in this patient population. So here's the take-home message. Those cervical cancer screening guidelines that we showed you on a few slides, those are basically gospel. Don't let board exams throw a curveball at you and think that that changes everything about that, or you think, oh, I didn't consider this. No, just ignore all that. Just follow those guidelines. And I say gospel as though that won't change, but they will change it all the time. But the point is, as of right now, that's all true and follow that. Now let's talk about prostate cancer screening. Unlike cervical cancer, screening protocols for prostate cancer are less established. Currently, screening is performed on an individual basis with no general guidelines to follow, which isn't super helpful, but in a way, it makes your life a little bit easier because there's not some strict routine that you have to follow. Additionally, the utility of prostate-specific antigen, or PSA, as a screening tool is hotly debated. So, PSA screening is unlikely to be the correct answer on exams. Fortunately, most males die with prostate cancer, not because of it. So for clarity, it's not fortunate that they die, but it's just fortunate that prostate cancer isn't the one killing them. Now perhaps that's actually the reason why we don't have a robust screening guideline for the general population. Because after all, what's the purpose of screening? It's to improve life or extend life. And if you're not doing that, then you don't really need to screen. So there's a lot of debate around this. But how do you prevent prostate cancer? Although there are some lifestyle changes that can be adopted to reduce one's risk of developing prostate cancer, for example, a healthy diet and regular exercise, very good ideas for any patient population, there are no commonly adopted prevention strategies for prostate cancer at this time. In other words, besides just trying to have your patient engage in healthy activities, there's nothing else you need to ask them to do. Which means for you, when it comes to exams, there's not anything commonly adopted that you need to worry about on your board exams. Now let's move on to colorectal cancer screening. So this is indicated in all average risk adults aged 50 through 75. There are several screening modalities and schedules that patients can choose from. And that can be frustrating as a learner just because there's so many different options, but we'll help you remember these. So what are they? Fecal occult blood testing every year, flexible sigmoidoscopy every 5 years, CT colonography every 5 years, and colonoscopy every 10 years. Now, all of these timelines assume normal findings on each of these tests because an abnormal finding would alter the screening schedule going forward. Also, it's important to note that high-risk adults should always be screened with colonoscopies, as colonoscopies are more accurate in detection of cancer than any of the other screening modalities. Okay, so in brief review, there are 4 options. The most accurate is the colonoscopy, which means a normal exam doesn't need to be repeated as often. So you only need to do that every 10 years. But then the other types of imaging, CT colonography and the flexible sigmoidoscopy, aren't as accurate, so you have to actually repeat those twice as often, so every 5 years. And then the least accurate of all of them is fecal occult blood testing, so you need to do that annually. Okay, now let's just focus on high-risk patients. What are the screening guidelines for these patients? Well, for patients with a family history of colon cancer, clinicians should start screening either at age 40 or 10 years before the age of diagnosis of the family member, whichever comes first. For example, if the patient's father was diagnosed with colon cancer at age 40, then your patient should have his or her first screening at age 30. If, on the other hand, the patient's father was diagnosed with colon cancer at age 55, then that would mean 10 years prior to that is 45, but you're going to want to screen them earlier than that, so 40. Now, after the initial screening colonoscopy, these patients should have repeat colonoscopy every 5 years instead of every 10 years. And for patients with Lynch syndrome, clinicians should start screening at age 20 to 25, and patients should obtain a repeat colonoscopy every 1 to 2 years. Now, for patients with familial adenomatous polyposis, or FAP, clinicians should start screening at age 10 to 12, and patients should obtain a repeat colonoscopy every year. So basically, if they have a genetic condition, then you're going to use a colonoscopy basically every year. Now, lastly, for patients with inflammatory bowel disease, such as ulcerative colitis, then clinicians should start screening with colonoscopies 8 years after the initial diagnosis. And patients should obtain a repeat colonoscopy every 1 to 3 years after that. So basically, they're diagnosed with ulcerative colitis, you've got this 8-year lag, and then you got to start screening them with colonoscopy. Now, as we alluded to before, anytime you get a positive test result with any of these screening methods, including colonoscopy, then you're going to make some alterations to continued monitoring. And how you alter is actually made on an individual basis. So that's unlikely to be tested on the board exams. In other words, just follow these guidelines, and if they have an abnormal test result, then it's going to be different than these guidelines. But don't worry about exactly how they will be different. So the pattern up to this point in this lecture is we talk about the cancer screening, and then we go right to prevention. However, in colorectal cancer, we're actually going to talk about surveillance and then talk about prevention. So in addition to knowing the screening guidelines, it's also important to know the basics of surveillance. And the surveillance strategy is determined by the stage of the cancer at the time you diagnose it. For example, with stage 1 colorectal cancer, those are characterized by the presence of a tumor in the mucosa and submucosa, and it's only there. There's no evidence of metastasis. And for those patients, a surveillance colonoscopy is recommended 1 year following surgical resection of that tumor. And hopefully implied in that is that you caught the tumor at this early stage and you removed it. And then you just want to follow it because they're a high-risk patient. So 1 year later, do another colonoscopy. And if everything was normal on that 1 year follow-up colonoscopy, you can actually relax a little bit. So just repeat the colonoscopy every 3 to 5 years. In other stages of colorectal cancer, the tumor either invades deeper to the mucosa, as in stage 2, or it spreads to lymph nodes, as in stage 3, or it metastasizes to distant sites, such as stage 4. And colonoscopy schedule for these patients is the same as for patients with stage 1 cancers. So that's actually fortunate for you because it's pretty easy. Regardless of the stage, you're going to do a 1 year follow-up colonoscopy. However, in these types of patients, there's a slight difference. So clinicians can consider CEA testing and annual CT scans of the chest and abdomen to help supplement that surveillance colonoscopy. And that makes sense because you're pretty worried about travel to lymph nodes and metastasis. So it makes sense that you're going to want to image areas other than just the colon. And the other thing you need to remember about stage 2, 3, and 4 that does not pertain to stage 1 is that surveillance continues lifelong for these patients. It doesn't just stop, you actually continue it. And the only time you actually stop surveillance in stages 2 through 4 is if it's pointless, like medically futile. Because remember, the whole point of screening and surveillance is to extend life or improve quality of life. And if finding something bad isn't going to change your management, then you don't need to continue your surveillance. Okay, now we can start talking about how you prevent colorectal cancer. So there are 2 main testable strategies. First is medical prevention with low-dose aspirin, which is indicated in patients who meet the following criteria. Age 50 to 59, they have a 10% or greater 10-year cardiovascular disease risk, no increased risk of bleeding, and that's pretty logical because aspirin is an antiplatelet, and if they have a risk of bleeding, then you don't want to cause a bleeding issue. So basically, if there's not a contraindication to aspirin, then you can proceed with this idea. The next criteria is they have to be expected to live at least 10 years following the start of this low-dose aspirin. And lastly, your patient has to be willing to take low-dose aspirin daily for 10 years. And again, all of these criteria must be met before considering a patient for prophylactic low-dose aspirin. Not just 4 out of the 5 or 3 out of the 5, all of them. Now, the next preventive strategy is surgical prevention with a prophylactic colectomy. And naturally, you're not going to want to do that for all your patients. Otherwise, you would just remove all the organs in all patients in the world. But that's not what we're talking about here. We're talking about patients who are high risk based on a genetic condition. For example, those with familial adenomatous polyposis. Now let's wrap up with a board-style question. A 55-year-old female presents to her primary care provider for routine follow-up care. She has a history of hypertension, hyperlipidemia, and type 2 diabetes. She does not drink alcohol, but has been smoking 1 pack of cigarettes a day since age 40. Her family history is unremarkable. According to her medical record, she had a normal screening colonoscopy 5 years ago, a normal pap smear 4 years ago, and an unremarkable mammogram 1 year ago. Her vital signs are within normal limits, and her physical exam is unremarkable. At this time, the clinician should remember screening for which of the following malignancies: A, breast cancer, B, cervical cancer, C, ovarian cancer, D, colorectal cancer, or E, lung cancer. So the correct answer here is choice B, cervical cancer. So let's go through why that is and why the other options are wrong. First, let's help give you an idea of why the other ones are wrong. So option A, breast cancer, is incorrect because the woman had an unremarkable mammogram 1 year ago. So that's pretty recent. And according to the United States Preventive Services Task Force, a screening mammogram is indicated in all women ages 50 to 74 once every 2 years, assuming the results are unremarkable. So this patient doesn't need another mammogram for another year or so. Now option C, ovarian cancer, is incorrect because this patient does not meet criteria for ovarian cancer screening. Recall from this slide that ovarian cancer screening is indicated in women with a family history of any one of the following factors: male breast cancer, bilateral breast cancer, diagnosis of breast cancer at age less than 50, multiple instances of breast or ovarian cancer, and 3 or more relatives with cancer secondary to Lynch syndrome. And since this patient's family history is unremarkable in that way, she does not meet criteria for ovarian cancer screening. Now option D, colorectal cancer, is incorrect because this patient had a normal screening colonoscopy 5 years ago. And recall that screening colonoscopies are indicated in all average risk adults age 50 to 75, and assuming normal results, colonoscopies are performed every 10 years. And like I mentioned earlier in the lecture, colonoscopies are the best and most accurate screening tool for colon cancer. And because of that, it has the most time between each screening episode. So every 10 years. So she's got another 5 years or so. Now lastly, option E, lung cancer, is incorrect because the patient doesn't quite meet all the criteria for screening. Recall from this slide that annual screening for lung cancer with a low-dose CT scan is indicated in patients who meet all 3 of the following criteria: age 55 to 80, 30-pack year history of smoking or greater, and the patient is a current smoker or quit smoking within the past 15 years. So even though our patient is 55 and a current smoker, she's been smoking a pack a day only for about 15 years, meaning that she has a 15-pack year smoking history. Okay, finally, option B, cervical cancer, is correct because her last normal pap smear was done 4 years ago. Recall from this slide that in females age 30 to 65 who chose to undergo cervical cancer screening using cervical cytology alone should have repeat screening every 3 years. And since her last pap smear was done 4 years ago, she's due for another screening pap smear right now. So in fact, she probably could have had this a year ago. So again, the correct answer is choice B, cervical cancer. And that concludes this section.